time to start.
Greetings, everyone, and good evening, and welcome to the penultimate session in the Masterclass series being brought to you by the members of the AO North America Hand Education Committee. Tonight's session is special because for the first time ever in the history of the AO North America Hand Education Committee, we have instituted the program of a partner nation. And last year we started this, and the first and inaugural partner nation is India. And for me, it is extra special because I get a chance to showcase the country of my birth as well as the country that so generously adopted me. So that makes this session very special for me personally. I must thank our master, Dr. Raja Sabapathy, and our moderator, Dr. Anil Bhat, for waking up so early. It's 4:30 in India. And I can't think of a better standard bearer to represent India than Dr. Raja Sabapathy. I have known Raja for over 30 years, and I have been really astounded by his spectacular work, and I must say a tad envious at his skill set. He has managed to convert his place of work, Ganga Hospital, into a world-class facility, which is the envy of a lot of places. So with that being said, Raja, thank you, and Mr. Gobinath, thank you. Anil, thank you for waking up so early. Anil, I will hand it off to you as the moderator.
Thank you, Chaitanya. Good evening, everyone, and good morning to my friends in India. This masterclass series is, as Chaitanya was telling, is special, and Chaitanya is special for all the things he does for the education in the AO Hand Education Committee, and I've learned a lot over these last few months being with him. To introduce Dr. Raja Sabapathy, I think it'll be an entire slideshow, but otherwise he's been my teacher, and he's the present chairman of Department of Plastic Surgery, Hand and Microsurgery at Ganga Hospital, and he's the present president of Asia Pacific Federation of Societies for Surgery of the Hand, and also the Secretary General of the IFSSH. He's visiting professor at many of these universities, and also the Vice President of Diabetic Foot Society of India. And he's been our president for the Hand Society of India earlier, and you would see on the screen the amount of publications and the awards and orations he's accumulated over the years. And I'm the moderator today, Dr. Anil Bhat from Kasturba Medical College, Manipal. Dr. Amit Gupta will take the Q&A from Louisville, Kentucky, and we have Mr. Gobinath, who is also the hand therapist at Ganga Hospital, who will be talking to us about the rehabilitation. This is the disclosure information of all the faculty here. And this is the basic agenda here. We start off with the talk by Dr. Raja Sabapathy, followed by the rehab discussion by Mr. Gobinath, and we take up the Q&A later. These are the CME credits, and you'll be sent a link after the conclusion of the series. This is the content validation statement of AO North America here. And all of you, I'm sure, are aware of the Zoom etiquette, but please do send in the questions or technical issues through the Q&A box for the moderator to review and ask the questions. The learning objectives at the end of this presentation would be to know the indications of replantation of amputated parts of the upper limb, technical considerations which determine the success of the procedure, steps that need to be taken to obtain an acceptable functional outcome, and to recognize possible pitfalls and develop strategies to avoid them and methodology to deal with them should they arise. So these will be the learning objectives for this particular session. This is the masterclass series which has happened till now, and the next one would be the International Roundtable, and we are quite excited about that. You will be not receiving a link of this recording as of now, but once the recording is edited, you will be getting the link for the YouTube channel. And this is the podcast link, which is now streaming on all these channels. Now I request Dr. Sabapathy to share his screen and to start his lecture. Thank you very much.
Yeah, no, thank you so much, Anil and Chaitanya and Dr. Amit. It has been a pleasure to be called to do this master class. The title that has been given to me is Technical Pearls in Digital and Major Replantations. And it has been put as normally call it as a minor replant and a major replant, and the division level is at the level of the wrist. This division is very arbitrary because it doesn't really tell you about the complexity of the procedure. It's just that in a minor replant, it's the possible complications, the possible systemic complications will be lesser. I think that's it. We will discuss in this talk of 45 minutes about the fingertip replants, proximal digital replants, transmetacarpal, wrist, and major replants. First, we'll go on to tip replants. If someone asks me what should be the first criteria, I think the first criteria we should have is that we need to believe that it's worth doing it. I think that's the first thing. See, if you get an amputation like this, functionally, if you don't replant also, they may not have much problems. I think that's true. But then if you replant, the results are really good. So these are the patients where they get a highest level of satisfaction. So we need to believe it's worth doing it, and then you can start doing it. There are quite a few things that have been told that if you do a replant in the tip, you get a cold intolerance and the number of work days lost and all that. And even in the thumb tip, they say even without the thumb tip, there is not much of functional loss. But then there are equal number of articles which say that the amount of neuroma pain that you get when shortening closures is done much higher than the replant. Cold intolerance is still there in fingertip shortening closures. But then the most important, if you ask the patients, they all say no, they love it. I think that's the reason why we start doing it. So technically, what are the things important? Once you decide to do, say here is a tip replant, the amputation of the thumb tip. And if you ask me, what do you mean by a tip? That is the part that is distal to the insertion of the flexor and the extensor tendon. I think that's the tip. So that means there's no tendon. The joint is still there. The first difficulty is that your assistant must be able to hold it tight and hold it nice when you start dissecating the vessels. Initially, sometimes we ourselves used to hold on with one hand, one hand, you hold it, and then we do that. And that's the way we do. So you hold that your two fingers or the ring fingers and you start doing it. But that comes up with a lot of experience. So initially I was doing this. This is a suture carrier that we get. I used to take a horizontal suture in the nail and pass it through 2 holes and then tighten it. So the assistant catches the carrier, and that takes away the wobbling, too much of the wobbling, and then only the final part of that he has to hold. So that's what we were doing it before. And that's how it looked. And then it got published in the British Journal of Plastic Surgery and made quite a few people. And another thing which my colleague Hari, he thought was asking somebody to hold like this. So this again is very good because you put it and then you can hold it round. So now you can find out the vessels. So this is another technique now which we found. This again is a technique which could be quite be useful. You see, once we do that and then we mark the veins and arteries, all have been marked. And how do we catch up these veins? I think that's very important. In a tip replant, if you have to get a dorsal vein, you need to have at least 5 millimeters of dorsal skin needs to be present. See, for example, it has to be like this. Only then you can get a vein. Otherwise, you need to get a volar vein. And these volar veins are very superficial. So if you take a thick skin flap, the veins will go off in the flap. So you need to almost raise up a dermal flap so that you can get the veins. And this is one of the things which I started here in the early part of my replant career. We did this. First time when you get an amputated part, you just squeeze that and you will find some red spots coming up. But you can do it only once, So I think you have to do it when you start. And you will find some sort of speck red. I think that's the place where the vein is there. So this again is an extremely nice technique, and you will see that it is now very close to the skin. And once you identify them, when you dissect the part, they're all very nicely seen. You know it's there and all that. But then you must always mark them. You have to mark them, because if you miss marking any of them, what will happen is once you fix the skeleton, you just will not know where they are. You will be wasting a lot of time in searching for it. I think that's very important. In a tip replant, it's not the size of the veins that's the problem, but actually it's the thinness of the vessel wall is the problem. So what we need to do, you need to really irrigate the field so that the walls open up, and then you should be able to suture it well. The one instrument which I love is the vessel dilator, because it is thin, and I use it as almost like a forceps to do this anastomosis. Then we struck upon another idea as to how to make it easier, how to make our life easier, particularly when you are doing it at the level of the nail bed. If you put in a K wire, you found it difficult because the arteries are deeper and the veins are superficial. When you want to do the artery, you do require a little amount of retraction. Since when you put in a K wire, you can't do that. So what we did was we sutured the veins, and we sutured the nail bed, and we didn't put in a K wire. So what you could do is that you can keep on suturing the nail bed up to the level that you want, where the artery comes up, and you suture the artery, put in some more skin sutures, and then you start doing the vein. And we didn't use the K wire at all. And all of us know that the distal phalanx is so adherent to the nail bed. And once you suture the nail bed nicely, I think you get a very good bone approximation. Also, this is one patient where at 6 months follow-up, the bone has also got united. So what do you do if you want to do this technique at the sulcus level? So you can, the nail bed is not there. So what we do is we take these type of stitches you take, horizontal mattress stitches you take, and then go ahead and do the same thing. Here again, we are not done a K wire, and we are sutured only the nail bed. See, you see the artery is deeper and the veins are superficial. So this helps us to have a nice view of the artery to do that. And that's the patient with 18 months follow-up. Tip replants give us a good result because you find that the joint is always already there, and the nerve has got only a very little distance to grow. They become an extraordinarily good results. So advantage of this technique of no K wire is that the nail bed repair makes it very secure, and it makes us comfortable to do the volar artery. And after I did this, when I was reading the literature, someone also has mentioned that the venous drainage to the medullary cavity is also facilitated. Do we do digital replants when you do not find the veins? There are no, if you see the literature, there are a lot of techniques as to how you should manage if you are not able to find the veins. But when we started, I just made it as a policy that I will not do a replant if I don't find a vein. And I did that just because if you have that as a mind in your mind, you will search for the veins a little bit harder. I think that's it. And once you spend a little bit of time, somehow you identify the vein, the results become so much better, and the post-operative period now becomes so much nicer. So difficult vein repairs, if you're very thin, I think this is a Japanese technique which we found. You put in a small proline suture into one side, you put it like this. So it avoids the back wall suturing, which we have used it on some occasions where you use it, and then before you do the last stitch, you pull it out. So that again is there. Have you used vein grafts? Here also we have used vein grafts. Vein graft is small vein grafts used for the artery, and we get these vein grafts for tip replants at the volar aspect of your forearm. Do we use sutures? Very, very, very rarely. I would say 0.5% of times in our experience we used a leech. But then if you have them, they are very good. They are very useful. But then we have used chemical leaching, that is where you shave off a particular area in the nail bed or in the skin and continuously keep on rubbing up with this. We write like this and then keep it on doing. And this is the patient where we found only the artery artery only replant, and then without a vein, we couldn't find a vein, but by chemical leaching, by shaving, and we got a very nice result. And this is very important you do the tips and in adults, because then only you can do it in children. And I keep telling people that you can't do replants in children if you don't replant adults. So if it is similar on the same token, I said, do you do a single finger replant? I tell them that if you can't do multiple finger replants if you don't do single finger replants. So because of that, we replant everything that comes in the way. If it is technically possible, we go ahead and replant. So going proximally, what's very important is that you need a shortening bone is one important technique, is one important component of a replant. When if somebody should ask me how much do you shorten, I answer this. We shorten good enough to get the two ends of the arteries and the veins easily together. I think that's the answer most of the times. Most of the times, that's what we do. And this is a useful technique if you get an avulsion replants. You can use the plastic glove and protect the soft tissues when you do it. See, this is a very special indication, when you have a proximal distal replant, an avulsion replant. And if you like to put in a K wire, so you got only the distal phalanx here, and you got an entire soft tissue here. It is quite possible that your soft tissues get entangled in the K wire. And once it gets it, that means you have to kiss it goodbye. So we hit upon a technique. This is a normal intravenous needle. You take it and then cut off the tip, and you take off the needle. That means you get a nice sleeve. I think it's exactly the sleeve which would fit in this much distance. So you use this and then put it on, and then you don't take the sleeve at all until you take it off. I think that's the important thing that you have to do. It's a very, very nice technique whenever you do not want to get your tissues entangled. The usual sequence is you do the bone, you do the extensors, you do the veins, and loosely suture the dorsal skin, because if you have to have fine hemostasis later, no, that's fine. So just and do the flexors, nerves, and then finally arteries. We do the arteries finally. Because it is easy to do stretches in a bloodless steel, and while survival depends upon the vessel repairs, function depends upon the quality of the repair of other structures, particularly if you want to do a digital zone 2 replants. Here, ischemia time is not an issue, so that you could do the artery in the end. The other point, technical important point, which we have learned is that if you have a multiple finger injuries, and see, as in this case, you got all the tips are injured, and you want to replant the thumb, but then you also have to do something to the other fingers. And normally we would have done two triangular flaps, 2 fingers needed triangular flaps, and 2 fingers needed cross finger flaps. If other fingers need something, please do those other non-microsurgical things first, quickly, and then do the microsurgery. Because if you replant and then after that doing them is not good, one. Second, you will do it very fast, and then you may not do it nicely. Okay, so for example, here we have done 2 triangular flaps and 2 cross finger flaps, and then we did the replant. So here the whole thing becomes nicer. So I think that's the way to do it. So do the replant finger the last, and once you do the replant, finish it, and then put the plaster. The vein grafts, we do use them. And as Bob Ackland said, the only time you waste in doing a vein graft is the time that you take to decide that you need one. The volar aspect of the lower third of the forearm is the source. You put it if there is tension. I think if there's a tension, and you must always use a vein graft. Many times, this can be avoided with bone shortening. If you are not able to avoid it, if you think the bone shortening will be too much, and you should do this, you must always remember that if you're using a vein graft for the artery, and if you're using a vein graft for the vein, do not reverse the vein graft when using for the vein. So that means you need to mark it well, which I will come to. Pitfalls during vein graft is that you never miss it when you do for artery, but then when you use for a vein, by the force of habit, you may do it off. So this is the thing I learned in Louisville. You just always ligate it apart proximally. Blood always flows through the open end. And everyone in the unit must do this, because someone will take a vein graft and you will be putting it, and then that is quite possible to do mistakes. So everyone in the unit must follow the same practice of harvesting the vein graft and marking the vein graft. Everyone must follow the same technique. You must be careful when you're passing the vein graft if the vein graft crosses across the joint. For example, if it's here, so if you put in a vein graft thinking that it is straight, and then if you don't fix it, what will happen is when you put in the bandage, if it flexes, the vein graft will kink. So you must think that you should be putting it how the finger, the joints would be towards the end of the procedure. I think in that way you must choose the length of the vein graft, or you must fix up the joint, which if it crosses the joint. When you do digital replant, are there any preferential vessels? Yes, there is a preferential vessels. If you read the anatomy, you will find that vessels on the non-border sides, I think they are all now bigger vessels. For the thumb, the dominant vessels will be the ulnar side distal artery. For the index, again, is the ulnar side. And for the little finger, is on the radial side. I think this will be okay. So if you are going to replant a thumb, you will preferentially look for a ulnar side distal artery because the caliber is bigger and it is easier to do. And I think the nature has made it such a way that the inner sides have got the bigger vessels, and the outer sides, the contact surfaces have got thicker distal nerves. And Graham Lister's book will say that the radial side distal nerve of the index is the thickest distal nerve in the hand. So this point is again is worth remembering. Do we do nerve repairs? No, we do. And I will say you must do. If not, the finger pulps get thinned out. Now you see the coning of the fingertip. And also now you could do it, nerve transfers you could do if you are just to get the ulnar side distal nerve. But just because you don't get a nerve, don't stop doing a tip replant or finger replant, because you could not get good results without them also. And they do get some protective, they do get protective sensation over a period of time. So what are the cause of problems? You are choosing a wrong vessel. I think if you are doing an artery, it must have pulsatile flow. And when you divide it, it must just spurt out. If it is not spurting out, you are doomed for failure. I think I will not do a replant if the vessel, the artery doesn't spurt out. Chuck, it has to go spurt out to the end of the table. If the anastomosis is technically good, the most common cause of the post-op problem is kinking of the vessel or hematoma. I think these are the things, fine. I always tell people, if you have a replant and then the problems are coming in 20 minutes, 2 hours, 2 days, and 2 weeks. In 20 minutes, it stops means that's a technical problem. In 2 hours, it stops means, it's hematoma or a kinking of the vessel. That's the problem. In 2 days means edema, plaster, so they are the problem. In 2 weeks, it's infection. 20 minutes, 2 hours, 2 days, 2 weeks. And the post-replantation, we always give anticoagulation therapy. And there's no established guidelines. If you ask me why I do it, no, I can't say. I think why I do, just do what I learned in Louisville. We do give 50 units per kg of heparin at the time of arterial clamp release, and thereafter, depending upon the weight of the patient, for adult, we give 5,000 units of heparin in 500 ml of. I was using low molecular dextran with one time an anaphylaxis, so now we use it in normal saline and give it to for 24 hours for 5 days. And once it's streamlined, it'll become a very fairly a simple procedure. Now we go on to a transmetacarpal replant. I would say that the replantation at this level is technically more demanding than other levels. Because multiple things could be injured, and they could be injured at different levels after replant. See, for example, if you're going to a thumb replant, there's only one column. And if you are going to do a wrist replant, there's only one column. But then if you have a transmetacarpal replant, there are 5. And at the end of debridement, you may find that the bones in different levels, they could be there. This could be a differential levels it could. And this differential loss is not restricted to bone alone. It could extend into the fingers too. The important to identify structures like the vessels and nerves first, and then radically escaped tissues. And if you don't do them, what will happen is even if you lose 5 millimeters of vessel, that means you need to have it. A lot of contamination will be there. And I don't debride the wound first. I just have a great idea as to where the vessels are and then do that. And then you do this. I think that's very important, because the loss of even 5 millimeters of good vessel length may make a world of difference. And when you do a transmetacarpal replant, I say you must achieve hemostasis in the distal part, even when you debride the amputated part, because It will help to prevent troublesome bleeding after clamp release. I think that's the whole of the mess it will be. So transmetacarpal replant is one replant where achieving hemostasis after the clamp release is difficult. This I found it. So I am more meticulous in achieving hemostasis when I do a transmetacarpal replant. We have used K wires because I find them very quick, simple. And of course, definitely they're not stable enough to start early movement. I think that has not been a great problem. SS wire box suturing, a rigid fixation by place can be done, but I always used K wires. And only thing you need to be careful with the avoid is of rotation. I think that's very important. That I think with experience, we should be able to get it. We pass the K wires distally in first in a retrograde manner. In the preparation of it, it is done, and then after that, it just push it in. Intrinsic contracture is a problem, and how do you avoid it? One way of avoiding it is you have to shorten the bone adequately. You do more arteries, as much of arteries as we want, we do it. And you deviate the intrinsic muscles well, and early sprinting and physiotherapy is important. This is a very important point. See, what the important point is, if you have a transmetacarpal replant, I always see the amount of connection here. If the connection is not good, that means you need to use a separate input to the thumb. If it don't, that means what will happen is initially it look good, but then the thumb will go. I think that's important. How do we get this? What we do is that now you need to get a jumping slide. What we now used to do is to get from the radial snuff box, you get a vein graft, and then you put it to the ulnar side distal artery or radial side distal artery. I think a separate inflow to the thumb is very important if the amputation is at the level where there is not enough of soft tissue connection between the index and the thumb. Skin cover usually is not a problem on the palmar side. But then on the dorsal side in a transmetacarpal replant, it's a problem. And sometimes we had wound breakdowns we had. And when you do a flexor repair, it's a tight flexor repair. I think it's a tight flexor repair will be there. And it causes a strain on the dorsum, and then it might break down. If it breaks down, I think immediately you're going to cover it as a flap. And anticipating flap cover is very important in a transmetacarpal replant, and many times we avoid it. What we do is this: you see, there's a vein that is exposed. Posterior interosseous artery flap is a very good flap for doing a cover in doing a transmetacarpal replant because the vessels are available. The other way of doing it is, if you do this, I'm going to give an example as to how it's going to be a very nicely good result. So that's a replant that we get. And we do this, and we primarily sometimes we have done a groin flap. I think it has really worked. I think that again is, you could do another free flap also. You can do another free flap, but then you can get away with a pedicle flap also. No, it's possible to get away. And that's the patient whom we have done. I think she has done, I got a very, very nice result. She's able to hold things. And the nerve recovery is always very good in these people. So it always gives them an excellent functional recovery it gives. So we'll finish off the transmetacarpal replant with an example. Here you've got an adequate amount of thumb web soft tissue. So here we are not going to do a separate input. So you do this. That's the flexor tendons. That's you go to the as many veins and as many arteries as possible. That's the rule. It's not that as many arteries, as many vessels. I think that ensures success. So the tendons are repaired. So all the nerves are repaired. And that's the type of result that's quite possible in a transmetacarpal replant. Now we go to the major replants, and here I'm very happy because this is one field where we feel that we have made a major contribution. The key to success is speed. The vessel size is not a problem. I think skill levels required are not an issue. I think the vessels are quite big. But what is important is speed, which means the infrastructure and the availability become the prime consideration. I think as a leader, you need to really concentrate on the logistics of getting things done. Two basic principles applied to my mind is that when you have a major amputation, still there's no good upper limb prosthesis with which high compliance rate. So affordability problems are also there. That's one. And second, distal to the wrist. So even if you use all the fingers, reconstructive options are available. I think they could use it. Now, proximal to the wrist, you are going to have groin flap, you are going to have multiple toe transfers. You can rehabilitate a patient. But then proximal to the wrist, if you have an elbow or arm, that means you don't have any other reconstructive technique other than a transplant. And if you have, most of the time they happen in a single limb, you don't do a, if you do, we don't do a transplant for a single limb now. So you have to really try hard to get the replantation done. So our philosophy is that whenever possible, replant. If our efforts would not endanger the life of the patient or put him to undue risk of morbidity. I think that's the thing. So I would say that the technical impossibility is the only consideration for not doing a replant. I think that's it. And these two lines are very important. If our efforts would not endanger the life of the patient or put him to undue risk of morbidity. I think that's very important. These four factors now must be at the back of your mind at any time you start. One is primary wound healing, primary bone union, hands that feel, and the fingers that work. I think these are the things. I think when you start itself, you must start doing this. Guillotine amputations yield good results. They're just proximal to the wrist. We have done a proximal costotomy and done it. This is more than 25 years. We have done this chap. This is a guillotine amputation. It's so easy to get a good result. But as we started practicing, we found that the number of times we have a guillotine amputation is very less. They almost always crush avulsion amputations, pull off, and then you see here again it's almost a guillotine amputation. So this again 20 years back, I think he's doing now. He'll done very well. He can do a tendon transfers. He has done extremely well. The incidence of guillotine amputation become rare, so most of them are crush avulsion amputations. So we thought we should have some refinements and techniques that are needed, and we summed it up in the Douglas lecture in the 2005. The most important goal, you need to reduce the ischemia time. I put it 3 times because reduce ischemia time, ischemia time, ischemia time. And I keep telling our people, if you have a major amputation, you have to think that the house is on fire. And you have to do it very fast. It rests more with organizational logistics than with technical skills. And how do we do that? Is in our hospital, we bypass the emergency room. Any major injury is just brought to the anteroom of the operating theater in the 4th floor, and immediately the patient is given a block. And radiology, all those things are done after the block. At the time when these things are happening and somebody is talking to the patient, the part is taken inside and the part is started being examined. So we'll talk to 2 patients and I'll show which is a proximal level. You'll find that we have not even done a fasciotomy. I think we've done it very fast. So arrival hemoglobin is 4.6. That means here the whole system has been geared for that. So they are the radiology is close to almost to the shoulder. We have to really think the airway, breathing, circulation. I think that's very important. I think you have to need to do that. And our anesthetists are very good in doing fast, examining the patient as a whole. And then they do that, they find that they got a grade 2 liver injury and involving the right lobe. But then they say it could be treated conservatively. So give a transfused blood. And we say there's a 2-team approach. 2-team approach means just not having 2 surgeons. It needs 2 microscopes, 2 operating table facilities, and 2 group of nurses. That's what is a 2-team approach. And we finished off at 8 p.m. That means in 5 hours and everything is over. That's the replant that has been done. And fixations, we always keep it very simple. I think we do it quick. And we have a guideline saying that no matter what, in a major replant, the fixation must be done or finished off in 20 minutes. I think that's the very thing. So the smile and dignity is restored. She's doing. She's able to even such a high proximal level replant. The median nerve is recovered and is able to do well. And as she grows up, I think as she grows up, we do a lot of secondary procedures to get them going. So you can do a wrist fusion so that you capitalize the finger flexion. And you can do a free functioning muscle transfers. That again, you can do it later. And now she's a happy married lady. So now another proximal replant will show, I think 2 showcases, and then we'll tell you how we attend. So this is an important thing. If when a patient comes, they do this. See whether it is suitable to replant or not. Beyond anything, If you think that the fingers are pliable, so the injury is here, and if you are able to do this, that means, the muscles have not gone drier, enough of things have not taken place, it's pliable. If the fingers are stiff, that means we won't do it. Or suppose if it is a forearm replant, what I would do, forearm amputation, what I would do is that I will move the thumb. If the thumb moves nicely, I replant. If the thumb doesn't move nicely, I don't replant. Here again, if the fingers are stiff, I won't replant. That is a fantastic, easy, straight way. But once that happens, what you do, you need to be continuously keeping it cool. I know cooling is impossible, but then continuously, as soon as you do it, we make a lot of glove bags and put the glove bags here also we'll put it. Now everywhere we put a glove bag and then wrap it up. Other than the area which you are operating, all the areas, rest of the areas are covered with ice. And then you start repairing it, you'll find because we shorten it, we don't really have much of soft tissue procedures we don't have to do. So now we tell that's possible. The first point I tell is speed. I think speed is very important. Second, if you have got a major replant, most of the times with the avulsion replants, you find that you need to exercise the muscles which should not survive. See, they are all hanging by the tendons. If you need to get this replant done, you need to exercise all muscles which will not get revascularized when you put an artery. Your standard of revascularization debridement has to be like this. And you need to shorten the bone, and then we do the replant. Then how does she function? She functions because the intrinsic, so she's holding the thumb in the adduction power comes up. The distance the nerve has to travel becomes less. The ischemia period is less. We do them very fast. So that means the intrinsics do recover. I think that's the key. Point number 3 is that you need to shorten the bone adequately. We have found that up to 10 centimeters, it doesn't give any problem. See, here you find a dislocated elbow and is so much open. And anyone will say, no, it's not worth replanting. But then what do you do if you don't replant? So we have shortened it 10 centimeters. We have created a one bone forearm. If you see a single hand, you will not find this a big problem. But then if you keep it together, you find it's shortened. But then not an issue. Functionally, it's not an issue because we attached good things to it. So now you find this. So he's holding his vehicle by the hand, which you got. So he uses a very good supportive hand. So when they had the hand like this, it doesn't really see. See, if you have a single hand, you will not see. So boldly shorten the bone. If you do radius to radius, they retain the pronation supination too, they retain. If you do a radius to ulna, that means then they cannot have a pronation supination is not maintained. And all sorts of bone fixation you can do. You can primary wrist fusion is possible, and very near to the elbow, your primary elbow fusion at this angle is we do. And at one stage, we thought we should try to salvage the elbow. And that again, certain things we have now techniques we have evolved. But then if you have a situation like this, where there is a highly contaminated and the elbow joint is available, you debride it nicely and then you shorten it on the other side. You shorten it on the other side so that the elbow joint is preserved. Here we got a child about 1.5 years old where it is through the elbow. I think it's through the elbow. Again, we wanted to retain the joint a little bit. So what we did was we took the amputated part. So this is the part, the other side. We took the amputated part and harvested the bone and then made the elbow first. And then shortened it very significantly on the other side. So that we thought we'll retain, we will get an elbow. And that's the child, where we got the elbow, that's the child that's growing in 1 year. And this him after about 8 years of follow-up. You see, they got a reasonable amount of elbow that is present and full. Because he's a child, the nerve recovery has been very good. So he's been using his hand for all activities. The other benefit of bone shortening is that now most often obviates the need for vein grafts, nerve grafts, and soft tissue procedures for closure. One shot, we finished. Point number 4 is that now you need to repair as many vessels are important. The vena commitants are very important. See, after you repair, see the amount of blood that passes out to the vena committants. So it is very, 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 very important. And you see, after you do the vena committantis, the bleeding stops. I found that if you do vena committantis on both sides, both the vessels, the amount of hemostasis, the effort at hemostasis is very less. So that again is a very important point, the observation that we have made. Apart from the superficial veins, I always know I do the vena comitatus. When forearm muscles are badly damaged with poor prospects of recovery, concentrate on good ulnar nerve repair. Usually we used to think of median nerve. And I found that you need to repair the ulnar nerve also very well, because what really happens is that we cannot get a great amount of flexion in the fingers, but then this thumb index pinch, you get, and they start doing, a lot of activities they start doing. You'll find that they're very powerful. I think it becomes, very powerful, and they hold things very nicely. This is a 10-year follow-up of the boy. The indications for replants have become extended now, because we know with secondary procedures we can enhance the function. So you'll find this the patient has been totally been avulsed. So we have done a wrist fusion. We have done, and all the segmental fracture is also fixed. And here you have got a graft, because now that you have got a graft, now we can't do this. Then after that we did a abdominal flap cover. We did. The third stage, we did a free functioning muscle transfer for finger flexion. So our ability to do our secondary procedures, it extends the indications for replants. So there's the island of free functioning gracilis. And you see, once she does that, now she's able to hold up with the gracilis. Now she's able to hold up at 2 kilograms of weight. So this, she's able to hold it up. People wonder whether primary nerve repair at a proximal level works. I think it works. And you need to think it works. So here is quite a high level of works. And we bank the radial nerve so that you operate with a graft afterwards. And you see, 2 years post-operative result, the flexion that he has got at the median nerve is very good. And afterwards, you could do tendon transfers, or you could fix the wrist. But then, it is quite possible to get good repairs. What are the other things, technical things which we have done to make it possible? In avulsion injuries, what we do is finding the proximal end is difficult. So what we do is, when the primary repair is not possible to be bank it. See, this is the nerve, this is the distal side. I don't know where is the proximal side. So what I do is I find how far does it come, make a small skin hole there, use a tendon tunneler, and then keep it very superficially and mark it. So next time we find where is according to the tunnel sign, a few months later, I can find where it is. I just open up there, open up here, and put it up with the nerve graft. I think that's very easy to do. The same patient, say you find you at the end of replant, that's the point. And later on, we open it up, and then we find out this is the only gap that we find, which we need to cover it. So that again is quite possible. So making secondary procedures easier, the most important requirement is that primarily you need to write a good operation notes, so that you avoid doing a lot of things. And point number 8 is aim at primary healing of the wound. And most of the times, because we do extensive bone shortening, you don't really require major help. And you be prepared for complications. See, we do a high level of replant. You see the tall tinted T waves, that means the potassium is high. And if you're doing it under block, that means they start sweating. So this is midnight now, 1:23. And I never take a chance. And we have tried it, and then we find it, go through a very difficult. So though you have worked very hard, that means if things go bad like this, immediately take off. I just take off the replant. 1:23, here is now 1:54. Pulse, everything is settled down. We never take a chance with a major replant, because we don't allow them to die. And the point number 10 is that good psychological counseling is very essential, because it takes more than a year to get a good result. So at that time, you need to keep up their morale. So in outcome, we have found 60% of them are fall into grade 1 and grade 2 chain, and only 20% in grade 4. So that means it's worth doing it. So we need to start with an idea that's going to work. It's the surgeon's belief in the procedure that's most crucial to get up. Then you push very hard. I think I'll give you 2 examples before I finish. So if we get a patient like this, we follow the same protocol. Give a block, examine distally. If you find an artery, think how you can do it. That's the avulsion replant. We go by the same way. I think that's the thing. We take it off all this and try to put it back. See, same lady. I think you got it. We are not even put a major soft tissue procedure except putting a skin graft in area. 3 years later, that's the same lady. I think you find that she has got an elbow is retained, so it's fine. There's the left hand. You see what all she is doing with the left hand. The left hand is used for steadying the things. And she could even lift up a heavy weight if she could lift up. I think this is just possible if only we do a replant. No process can give this. And you extend it even further, the 4/4 amputation. I think here you extend it. Conventionally, you'll think, this can't be replanted. So here again, go through the same way. Don't think it's not possible. You go through the same way. And you think of how quickly it can be replanted. Replantation is done. But if you really see the time, he arrived at 1 hour, 10 minutes. So total time is replantation time that it taken is 4 hours. I think we done it not quickly. And then we start the rehabilitation process. And 1 year follow-up, now you will find, because the radial nerve has started recovering well, he has got a good triceps. He's got a very good triceps. What we did was triceps to biceps we did, so that flexion is good. And you see, the ulnar now has become recovered very well. Ulnar now, this thing, so it is good. So what we did was side itching of the ulnar of FDP to, we did the other one. And we transfer the dorsal sensory branch of the ulnar nerve to median nerve to provide some sensation. So now you see, he's got it. 4/4 amputation. He's able to do this. Now he requires only a claw correction procedure, so that now you'll do better. That's the 3-year follow-up. So the goal is the net result is that the patient must do better than what he would do with amputation without putting the patient to undue risk. We don't take risk at all. If you think it's a problem, I take it off. But then, we should see to that we don't get into that spectrum. Again, that's it. So this is the last slide. In my talk, quite a lot of people have asked us now, how do we do that? So in the last Olympics, after an athlete won the medal, she was asked, how he achieved it. He said, gasping after the running up, he said, I trained when I liked to. I trained when I did not like to. I kept on training. I think it's very true in microsurgery also. No? You have to replant when you like to. When you don't, you have to replant when you don't like to. You have to just keep on replanting. And then, you'll be very good. So thank you so much for the opportunity to share our experience. Thank Dr. Mudgal, Anil, and Dr. Amit Gupta. Thank you so much.
Thank you, sir. Thank you for taking us through that fascinating journey of replants. I think each slide is a chapter, and there are 1 chapters for people to go through again and again. And with that such beautiful work, I don't think it will be complete with a very dedicated rehabilitation and a very, very compliant patient, or motivated patient. I would like to invite Mr. Gobinath to share his slides for the rehabilitation of these replants. Mr. Gobinath worked with Dr. Sabapathy at Denver Hospital, and he's the best foil for this kind of a combination of surgical magic with rehabilitation process. Over to you, Mr. Gobinath.
Thanks for everyone. That's Rajasabapathy sir, Anil sir, Amit Gupta sir, Chaitanya sir. Thanks for giving me an opportunity to present my rehabilitation program here. So just start with my talk. So rehabilitation after replantation, it's a bigger challenge as well as after a big surgeon speaking. No, so the rehabilitation speaking by a therapist is also a little bit high. So what to say? Such a legend talks. So next talk will be mine. So everyone will be in eager of in the what will be the talk. So here, so I'll go 1 minute. Okay. So two things I have to say. So one is replantation and revascularization. So replantation is a complete amputation where the injured part is longer attached to the injured, to the patient. So revas, some portions or some tendons or nerve will be intact. So the intact part matters the outcome. So I want to mean this the replantation and revascularization. So complete amputation is like there will be no intact part. So we have to repair all the structures. So in revascularization, there will be some structures will be intact, which matters the outcome at the later stage. So now at this time of period, the microsurgical replantation is technically feasible from the level of DPX to axilla level. So only thing, the replantation is not success when the survival of the replanter is. The success of replantation is the patient how uses the replanted limb. So many papers support the functional outcomes of replantation rather the prosthesis. So replantation at any level yield a high level of satisfaction, specifying the sensation and the psychologically well-being. They use their own limb, so that matters. So the article supports, most of the articles support the replantation rather than a prosthesis and revision amputations. So hand rehabilitation is such a bigger challenge after such major surgeries. So it needs a long-term follow-up, makes a patient for further queries whether how long it takes and how better they will be. So it takes times to do and make the patient to control that it will be recovering, you'll be able to use that hand, the replanted limb. So what protocol to follow? So since all the five structures, five systems, arteries, bones, nerves, everything has been included, everything has been repaired. So each structure has a time limit for healing. So we have to fix a time mentioning all the things, and there is no time frame till now when the therapy is to be started. So everything is says that how early we start, it gives the positive outcome. So the first goal of a replantation is the survival of the replant limb, and second thing goes for the how the replanted limb is going to hold or carry or oppose with the other extremity. So that will be our main goal when it comes to the replant. So first 3 weeks, so it will be of immobilization period for the replanted limb, but not with the patient. The patient is not going to be immobilized fully. So we have to mobilize him how early we do it. So the general body condition will be high, and we can take up the time with the patient to speak with them to keep the morale high and educate the patient. This has to be working on, and the replanted limb will going to work, and how long it takes, and how the recovery will be there. And we also will have a time the what are the structures are being repaired, and we can examine in between how the replanted limb was and what are the structures are being repaired, and we can have a time of taking a therapy plan. And when to start the therapy is how early, I said it's how early is possible, and we have to look upon the how the stability of the fixation is and how stability is the bone is going to union. So if there is no more procedure like a skin grafts or flap is going on, so how early we can start the therapy. So other thing is, in our setup, we at least start at the early of 3rd week. So first thing is I have to change the slab to a splint, where the protective splint will be of from 6 weeks to 8 weeks. So the position depends upon the structures repaired and how the repair was and what are the structures have been repaired. So we usually prefer a dorsal side, either it's a mid forearm level or distal forearm level. You prefer a above elbow splint, or if it is below the wrist level, you go for a dorsal blocking splint with a thumb support. So we usually prefer for more of flexor power rather than extensor. So once flexors has been input, they can able to use more, use the hand early rather than strengthening the extensor. So we prefer for the flexors. So by 3rd week, we'll start the therapy. We say it as early protective motion. So it's like a tenodesis movement, like when MCP is flexed, the IP will be extended, and when IP is flexed, the MCP will be extended. So this protective motion is said as the tendon gliding is done without any tension on both the sides, flexors and extensors, and prevents the joint stiffness. So we can go for passively with the early protective motion and slowly increase to the active. So ultrasound and kneading massage to prevent the additions. We can start by once the wounds have been healed well, and by the end of 4 weeks. So our preference how early the wound heals, we can start the scar massage and the ultrasound therapy. So next, by 5th week or 6th week, we can go for the early protective motion of 2nd phase, that is with the wrist flexion, MCP and fingers should be extended. All fingers should be extended from the MCP level. And when wrist has been extended up to 30 degrees, the fingers can be flexed. Not beyond the 30 degrees, it will force more on the flexor, wrist flexors. So with 30 degree of extension, you can fully make a fist of the fingers. So this also will go with passively and then go with slowly of active motion. So stimulation to make the repaired structures to glide well and for the denervated muscles. So this will be started by 6 weeks, and it also promotes the tendon intrinsic tendon healing and also makes a muscle property to maintain. So after 8 weeks, the therapy will be somewhat more aggressive, and if the tendon starts acting, we can go with graded stretching exercises and as well as the strengthening exercises. So as long as the edema is also a main problem in these replanted patients. So we have to take care of the edema. So like Coban wraps for the fingers and the compressive gloves for the hands, and with protective motion and the edema control will sure increase the tensile strength and the moments. So only thing, because we have to give a caution to the patient that there will not be there will be no sensation on the hand. So they'll be careful while handling in hot and cold objects and sharp hand. I think the caution should be given to the patient every time. So once they start using it, they'll not be aware of that they can be able to hold a hot glass or they'll be getting burns or something else. So every time we have to give a caution that there'll be no sensation. Be careful on holding a hot and cold and sharp objects. So 8 weeks, we can give a customized plan that promote the acting tendons to get it strengthened. So we give like a out triggers like to strengthen the finger flexors as well as to maintain the finger and extension. And we give a flexor trigger to bring the MCP more of flexion. So a 10 to 20 degree of MCP flexion will promote more to hold the objects whatever they want to carry, hold it. So it's not only the therapist and the patient has to do it. So we teach the patient also do. So because 1 or 2 sessions is done at the physio department, and the other time the patient is keeping the whole hand and whole time ideally with the splint, it's not going to work. The stiffness will not go up. So we advise the patient to do the exercises every 2 hours, and we'll give the flexion trigger and out trigger springs to be used intermittently. And another thing, they have to do the massage continuously, and it promotes it. So the tendon gliding and how active the muscles starts work, the strength will be improving it. So the resting split will be used only at that night, and intermittently they have to use the hand too. So whatever the replant level is, either it's a fingertip or to the axilla level. So the sensory has to be the main role. So even the fingertip zone 1 level of replantation, there'll be no motor loss, but there'll be a sure sensory deficit there. So once the patient starts moving to PD, 2-point discrimination, we have to start the sensory re-education. So the sensory education will be started from the larger objects to smaller objects, and the textures what we use should be from the rough textures to the soft textures. So how we can flow it. So we have to make the patient to feel the shapes of the structures and texture of the object with the eyes open, and make them to feel with eyes closed and try to identify what the object is and how the texture is. So they have to do repeatedly till they able to confirm the objects with eye closed. So textures can be of different types like sponge, cotton wool, rubber, sandpapers, velvet. So it doesn't matter the objects and structures. It doesn't need a special sensory education kit to do the things. So the sensory education is like make the brain to perceive the object or textures what they feel to pretend to learn the brain what the structures and perceive the sensation what they feel. The sensation will be altered. They have to perceive it and interpret to get it correct sensation. So we have to set a rule that whatever the object they carry, they have to feel the structure and shape of the structure and how the feel is. So these are the things of everyone carries in the daily living. A mobile phone, a hanky, a watch, pen, some coins and keys. So whenever they touch a object, they have to carry a object, just feel it. So what it is and where it is and what shape it is and what texture is. So every time they have to feel it. So it's not just holding it. Once they start feeling it, the sensory receptors will activate and gives a sensation. The brain will interrupt to get the correct sensation. So at the fingertips, we can do it in this way. Some what are the text it's available. So just place in a 2 sets and make it close with eyes, or we can close it upside down. So try to feel on the fingertips and try to identify and match it. So once you can match it, you just place it to finish all the textures what you have. It's only the three, it's not a three. So you can match how many times you can. So only thing, we have to open the sensory receptors. So till you point out correct, you can repeatedly do these things every time. It's not a set of one. We can, once you can identify one set of things, you can go for the next. So how many, what are the things you have? Shuffle every time. So other thing, so once you get the motor, muscle starts working and the sensory is also okay, the patient is not able to work at once. So we also faced many problems. So the motor will be having a reasonable power and sensation is good. So once they make them, ask them to use a hand, definitely they can't use or carry or hold the object on the first attempt. They have to repeatedly practice or prehensions to hold the objects. So there'll be no coordination between the fingers and thumb on the wrist. So once repeatedly practicing it, the brain will learn and adapt how to use a hand. So definitely the activity making the patient to use a hand is one part of the therapy, and make them to sit in the department and make them to use a hand for all the activities. So at least holding things and picking up things will definitely increase the muscle strength, as well as the patient will have a confidence that they can able to use a hand, they can able to use a hand for some activities. So slowly the strength will improve, we can increase the activity still more. So in other things, so once they can able to use, we also have frequently examine the recovery. So we have to take a post-operative assessment from the 3 months to 6 months, and every 3 months it will be analyzed. So what are the things should be taken is from the first performer, we have to get a detailed report of the patient personal details, as well as the what are the structures repaired and what are the tendons has been injured, and as well as what are the structures has been repaired, what are not there. So, and the range of motion and strength measurements and motor power, and main thing the sensory. So in many articles, CHENS criteria has been set of the outcome score for which quantify the quality of the replants. So CHENS criteria has been taken. So many of the patients comes under with the CHENS criteria. So as SRS said, also the 60 to 70% of the replants comes under the grade 1 and 2, and 20% of the people comes under grade 4. So here are a few examples of what we rehabilitated of different different replantation patients. And here is a version of distal proximal forearm level. The patient can able to use a hand for picking up activities, and definitely they can able to carry, and they are able to use a hand better than the prosthetists. And here's a cross hand replantation where both sides has been affected. The right side hand has been fixed to the left forearm. So after almost 6 months to 8 months of follow, the replant limb has been started working to use his hand for even eating, and able to lift a chair which is almost weights of 4 to 5 kgs. And it took a long-term and regular follow-up to make him to rehabilitate it. See, even thumb flexion has been good enough to hold some objects. And this is a transmetacarpal replantation where it needs a secondary reconstruction for the lumbricals. So they had a good range of motion of all fingers. They can able to fully make a fist, and they can able to extend fully. Even thumb can be opposed, even it has been seen as has been injured. So this is a single finger replant. The fingertip has been injured. The baby can able to hold a small object, and even they can use a replanted finger to write also. So what are the problems in rehabilitation? So only thing, it needs a long-term follow-up. So it's not possible when the patient is far from the department and far away from the place. And main thing is it takes a 6 months to rehabilitate them to use a hand. So 6 months of jobless and their affordability of traveling and staying at the place of rehabilitation, and these matters. So when we refer to the outside also, so it will be a bigger challenge how it goes to be. So we have to get them regular follow-up, and sometimes we get the implant infections or some infections at the wound healing part. And if the therapy is not regular, the outcomes will be sure it will be a problem. So these are the problems we face it, and other things. So it's not a only the surgeon or only the therapist. Even we with the combined team with the surgeon and the therapist, and intermittently speaking with the patient with the surgeon, we get an expert opinion. So whether we can progress at a stage where we need a opinion, and we can go for a secondary surgery, and we can get a opinion. We can progress the therapy, or we can make the patient to do well. So as of now, my summarize the talk, like major replantation takes more than a year to reach a full potential, and it's not the replanted limb is going to be 100% of functional, but at least it reaches to 60 to 80% of excellent results. And moreover, the guillotine amputation gives good results rather than a avulsion amputation, and children will be recovering more than an adult. So, and also the secondary surgeries will improve the outcomes in major replants too. So take home messages like each injury is different and each repair is different. So each patient has to be customize the therapy and give the interventions according to the repair structures, and it needs a long-term follow-up. And definitely we have to educate the patient how long it takes, and as well as the therapy. So it's not only the therapy is done by the therapist. The patient also cooperate to do the therapy in the home, and each time, every time we have to examine and we have to refine the therapy. So success is not the survival of the limb or using the hand. The patient has to go back to the work. It's a success of the definitely the success of the replanted limb. Thank you.
Thank you, Mr. Gobinath, for that wonderful showcasing of how important is rehabilitation to complete that very good replants. And I've personally seen how holistic the management is at Ganga Hospital with the surgeon and the therapist departments, and how it works for a functional kind of viability. That's what I would call it. I would now hand over the session to Mr. Amit Gupta, if there are any Q&As pending, or if he would like to ask some questions to Dr. Sabapathy.
Well, Raja, it's a beautiful lecture as usual. Fascinating experience and great cases. I have to tell you a story. When it's when Raja's early time in his life, after he finished his fellowship in Louisville, he went to work in Cannesburn, which is a great microsurgery and plastic surgery unit. And there he was in a peripheral hospital. It's called the Law Hospital in Carluke, way out in Scotland. And there's a trauma came in, and this patient had amputation of the leg and an amputation of the thumb. The trauma people were going to throw the leg away, and he said, "Oh, no, don't do that." So he, in the peripheral hospital, under loops, he took out the big toe and did a transplant, did a toe to thumb transfer in a smaller hospital as a resident. So you can imagine this was a harbinger of great things to come for Raja. So he's shown that in the future and established a great unit. And those fellows from around the world, I'd encourage you to visit his Ganga Hospital and see for yourself what the wonderful work they're doing. I've been answering the questions online, Raja, but I have to ask you some things. One of the things that you mentioned, and one of the things that we learn and emphasize from our teachers in Louisville, is that you will never regret doing a vein graft, but you will regret not doing one. So always, if anytime you have the opportunity to do a vein graft, even in the smallest replant. For example, in ring avulsion injuries, one of the things that leads to failure, you can have a beautiful vascular repair, but one of the things that leads to failure is the dorsal vein repair, because the skin dies, the vein dies, and secondarily the artery will die. How do you deal with that, Raja?
The best way is to prevent it happening. So that's what I said. I always remember Bob Ackland telling, the time you regret is the time you waste is the time to decide that you need a vein graft. If the vessels will not come in easily, that means no matter what you are dealing, whether you're doing a tip replant or doing a brachial artery repair, please put a vein graft. I think that's the message that I say. And the next thing is, when you put in a vein graft, you see that the vein graft must lie on a good bed and it must have a good cover. I think that again is important. If you many times people put a vein graft and over the vein graft they put in a skin which may or may not survive. No, that's no. So if you put in a vein graft, that vein graft, though it carries a lot of blood, it also has to survive by becoming viable. I think that's the concept we have to understand. And just because the vein is carrying a lot of blood, it's not going to live. It must lie on a good bed and it must have a good cover. That's very important. So whenever I put a vein graft, I take a muscle, or I never take a chance putting a something which you can worry about. Suppose you put a ring avulsion injury, or you put in a vein graft, you put in take a flap from neighboring finger and then attach it on, do something. But then you must have a good cover.
Thank you. The other things that you emphasize were very important points, and I don't want these to be missed. One is shortening, bone shortening.
Yes.
Fascinating. For these major replants, bone shortening is fundamental. You get rid of so many problems.
Yes.
You get rid of complex fixation of the bone, you get rid of length issues, and that's an absolute must. And you can shorten the bone, especially in the arm and also in the forearm. You can shorten tremendously. The other thing is debride
Yes.
muscles, which are not going to survive.
Yes.
Transmetacarpal amputation, I'm glad you emphasized that. Take away the intrinsics. They're not going to make it. So take them away and do the rehab appropriately. In the forearm, take away all the muscles, and you can come back later and do tendon transfers. You can do muscle transfers, but primarily get rid of those others. There'll be a nidus of infection, and they will cause problems for you. So those things are very important to emphasize. In major replants, you talked about speed, and that's why the logistics is very important. You can't do it as a one person doing a replant. It has to be a whole team. And you see how many people are there in Coimbatore and how many people are there in Louisville to do this. So a team approach is very important. Do you ever use perfusion or?
Sorry?
Do you use perfusion, blood perfusion, or UWC?
Very, very rarely, Amit, because we have a formula. That is, if you are not able to get the blood in by the 6 hours from the time of the injury, not from the time they come in, maybe you'll just put in a plastic tube and then put in perfuse it. But the problem of perfusion is, if you perfuse, you need to have a lot of blood. Because you are just getting open end, so you need to keep it. And we have written about it. So there is nothing in the literature which states, suppose if you perfuse it for 5 minutes, how many extra time you get for replant. So I used to think that if you do it for 5 minutes, you get about an hour extra for a replant. That's it, we get it. So more than perfusing in our center, because the team is good, we just go ahead and replant. We just go very fast. and then do.
Would you replant the artery and let the veins bleed out?
Yeah, we just do the artery first. We put the vein replant, vein bleed out a bit, and then close the artery again, and then do the rest of things we do. I think that's the way.
Yeah.
So the essence is, go fast. It's just like the cardiologists now, they say door to balloon time. I have taken that quote from them. Door to balloon time. So arrival to flow time. Okay, that has to keep it now very, very short.
Yeah, it's only possible with a good team and a good
good team.
Yeah.
Yeah. 24/7 you have to be there. The 24/7 you have to be prepared for
very
that.
Good. Raja, thank you very much. That was
Thank
excellent.
You, sir.
And appreciate all your presentations.
Thanks,
Anil,
Amit.
all yours.
Dr. Amit, would you like me to share the case?
Yes, please. Go ahead. Yeah.
So as they were speaking about avulsion amputations, especially, so this was an interesting case which we had a 28-year-old young male coming with an industrial.
Mantente a la derecha hacia carrera auxiliar, dirección 29 calle.
Industrial worker presented to us with left index finger avulsion. He came in 3 hours post injury, and these were his clinical pictures, and you can see the tendon, the FDP especially, was avulsed completely here, and these were the X-rays of the patient. And going by the classification, basically it's an avulsion with complete deglobing or amputation. I would like to ask Dr. Sabapathy, how would he counsel the patient, or what procedures he would have in mind in terms of the management itself at this point?
Yeah, thanks, Amit. We face this problem now and then. So we tell them that the first option, the best option is replantation, we tell them. And the question they ask is, will I feel and will it move? And because it's an avulsion through the DAP joint, that joint cannot move. So that means we need to fix it. We tell them not to worry, because the FDS is already inserted anyway. So you don't have to repair. So that means the finger, the proximal interphalangeal joint will function anyway, because the attachments are there. And you are going to fuse the DAP joint. So we tell them that you will have this movement will be there. And surprisingly, you will find the nerves there. And even if you find one nerve, it's fine, one. And they do get a protective sensation. We tell them, in addition to the replant, we might open the volar aspect of your wrist, just the skin, so that we might be needing a vein grafts, we tell them, and then go ahead with the replant. And all avulsion replants people, now we will, first choice is replantation. And most of them agree. And they do get good results.
Anil and Raja, I just want to add a little thing. In my practice, this will definitely be a revision amputation and send the patient home. Index finger in a young person, no question in my mind.
So these are the options which would come into play. So as you said, reamputation or replantation, or cover it with a flap and later mobilize and do secondary procedures. So these were things in the mind of us also when we saw this patient. Chaitanya, would you like to come in?
Yeah, I think, I agree with Amit. I don't intend to sound nihilistic, but in my practice, this may probably end up with a revision and a ray resection, because it's a one operation, it's an overnight stay, and the patient would be rehabbed and back to function within 2 to 3 weeks. But that's me. I'm not as skilled as Raja is. So
we give the option to the patient. We tell them, if you do this, this is the cost, this is the time you spend, and you go.
Yeah.
Or if you like to have this, you have to walk through this long mile. You have to walk through this and then let the patient decide. But then one thing I will not do is cover it with a flap. I think that's no way. I think the covering it with a flap for the index finger is no way, because that makes it lousy. But whereas now, if you successfully do the replant, that's fine. Otherwise, no, it's an amputation is the best. I think that be there. It's one shot you have to succeed, and you will not be putting like if you are not finding the vein, or if it's, even suboptimal. Anything that is suboptimal, that means you need to go for an amputation.
So
I
I think Raja raises some very good points. But the one thing I would say is, for each surgeon, he or she has to be comfortable admitting their strengths and their weaknesses,
Yes.
Yeah.
knowing when they can't do it.
Chai,
Yes.
it's not only the technical expertise of the surgeon; it's what the patient's going to use.
Of course.
Patient only.
And
Yeah,
patient's going to bypass the index finger and start using the middle finger. So you've
Yes.
wasted all your resources. And I'm telling you, in my practice, I have no doubt in the index finger border digit, it'll be an amputation, not a radius section, but I'll take it off at the metacarpal level.
The reason I mentioned ray resection is because I find that aesthetically far more pleasing, and that 20% loss of grip strength is not as evident to most patients in my experience, but aesthetically it's wonderful to look at.
Yeah, I don't do the radius section right away. I do. I would
Sure.
have them ask for it.
Yeah, sure.
Yeah, I think the most important aspect of that would be probably the shared decision making between the
Right.
patient and the surgeon. Yeah. So basically, this was the intro evaluation of this patient. So what we found was that the distal phalanx is completely off, and we could identify one artery in the amputated part, two veins dorsally, one digital nerve, as Dr. Sabapathy was mentioning. The digital nerve was there. FTP, as I showed, was completely avulsed. FTS was intact. The terminal phalanx was separated completely. We did go ahead with the replantation in this patient. DIP, we fused the DIP. We had that one artery, so an end-to-end from the ulnar proximal to the radial distal at about middle of the middle phalanx level. That's where the anastomosis happened. Two dorsal veins near the index base, and the one available distal ulnar digital nerve was coaptated proximally. And this was at day 5, and this is day 14. A good improvement in the color and the turgor, and this is 3 months follow-up with FDS is intact, so he was able to get that some amount of movements there of the PIP, as Dr. Sabapathy was mentioning. We actually had published about, I mean, any of you do any kind of scoring systems for salvageability in any of these fingers, especially amputations?
No, we have not done them, but you read about them. So I think it's just quite useful if they basically they have to go and function. They have to go back, and
Yes.
that depends upon some amount of sensory recovery and stability of the finger. You must not have pain. That's the most important thing.
Yes. So this was almost 1,500 patients, and what we found, especially for this amputation patients, Strickland scoring is one probably is forgotten almost, but it's a very beautiful scoring which we have, which I think was one of the only scoring which talks about the vascularity also. There's a component for the artery, there's a scoring for the artery. Of course, we don't do it routinely, these things, but this was done as a study. And we found that the Strickland scoring is basically about, the score is 10, and worst score is 10. And then patients who had more than 10, also when we did the salvage, they survived, which means to say that even a finger like this with the kind of avulsion injuries could survive in this. So again, coming to, as Dr. Sabapathy is telling, it finally has to function, and scorings might not be really useful in the context of just the scoring itself. You need to take into account a lot of other factors, and but then almost 14% of those patients who had worse scoring also survived. And one of the example was this particular case. This is the scoring system where only artery part is shown in the Strickland scoring. And I think What we learned was basically to not give an exploration without examining these, the vessels. And I think decision can be taken after that, whether you go for an amputation or for a replant. And as we all told, I think shared decision making is very, very important, pros and cons of each of these procedures. And finally, it's, as Dr. Amit Gupta was telling, it's about the patient's motivation and how would he or she would like to use those fingers, and not bypass that finger at the end of the day and waste all the resources which has been used earlier. Thank you. Thank you so much.
Raja,
Yes.
before we start wrapping up, I have one question for you, because this is a situation that we face all the time. I mean, maybe you don't, but let's say you replanted a single digit. It's in
Yes.
zone 2,
Yes.
or maybe 2, and it's been a long day. You've finished doing everything. You're
Yes.
about to start closing the skin, and now one of the fingers or both of the fingers start looking pale. Can you walk me through your decision making about what you do at this point, please?
And if the bone this thing what I put, if the tendon repair is good, if I think ideally if the finger survives, I will get a reasonable amount of good movement. I think you have to open up and redo it.
No. So you haven't finished closing.
Yeah.
You're still in the operating room, and the
Yes.
finger is starting to look pale.
Yeah.
What are the intraoperative decision-making surgical steps that you go
All
through?
right. Okay. So first, we will wait and put in a lot of warm saline. Warm
Okay.
saline will put warm saline. That's the first one, and then I always look up at the monitor. How is the general condition of the patient? See his blood pressure, see the room cold, temperature.
Yeah.
I think everything. You have put the patient as a whole.
Yeah.
Okay, that's the next thing you have to do. Sometimes the pressure may be low. They may give a lot of sedation,
Sure.
so you have to give a pressure. So next, after that, then you see maybe wait for about 20 minutes. Okay, because the spasm to go. Because in that time, if you do something, you'll only be doing the waste. If you go proximally, it will still be in spasm.
Yeah.
More and more you cut, more and more it will be in spasm. So if after 20 minutes you find the rest of the places are warm, pink, flushy, okay, then you go to your proximal artery, then you think of a vein graft.
I see.
Then I'll think of it. Then when I think of a vein graft, I'll think, okay, you're taking on to the next step. And at this time, it's a zone 2. And then I'll also weigh pros and cons that what is the potential function this fellow is going to have.
Yeah.
Okay, because I do not want to have repeated procedures. If it's not going to survive at the end of it, I leave the operation room, removing the finger and going.
Yeah.
So I do not want to wait for 3 days and all that. So and then take it off. So it just be one single shot.
Yeah.
Okay, that's our point. So we need to have, because it must be very cost effective also. I think all the things that we do, I think it has to be cost effective, and cost of care is an important thing in all economies. So that will be my thought.
Thank you. Yeah. Anil?
Dr. Sabapathy, coming
Yes.
to the cost, if I would like to know how the anesthesia is managed, especially multiple replants or long procedures. Have you gone on towards wallet, or is it the same anesthesia with the
Same.
top of which is,
No,
yes.
we just do a brachial plexus block. So what we started brachial plexus block, and then that comes around nowadays with some the bupivacaine and the adding steroids and all. They just come for about 15-16 hours. It comes, and we have never had an occasion to do very, very, very rarely. Even when they did a 5-finger replant, it took 17 hours. And the last 2 hours, we gave GA, not because the block wore off, but the patient was finding it uncomfortable to lie on the bed.
Yeah.
That's a very bigger problem. Finding it difficult to lying on the bed continuously. That's the problem. For that reason, bilateral replants we are done with bilateral blocks. I find the cost of care is tremendously down. If you just do the block. That's a very, and you need to give good anesthetist. Now with the ultrasound coming in, initial period that depended on the blocks depended upon skill. Now with the ultrasound coming in, anybody can do it, right? Most people do it off very comfortably. not anybody. I think it makes it much more easy. Yes.
All right.
I've seen the magical hands of Dr. Bhat, Dr. Ravindra Bhat in that. Yeah, I think we really missed him.
So yeah, in the initial period, when the ultrasound was not there, it was a lot of skill was there. But with the ultrasound, it became technically refined. It has become very technically refined. It is now easy to teach, and it has become easy to practice. And the success rates now are now quite high, easy.
Okay, that's Anil. I think
Yes.
it's time to wrap up.
Yeah.
So,
So thank you so much. It's a great opportunity to meet all of you and share our experience.
Can you bring up the So let me be the first to thank our master, Dr. Sabapathy, his therapist, Mr. Gobinath, and moderator Anil Bhat, and our Q&A person, Dr. Gupta. This was really spectacular. You realize how much you don't know when you listen to someone like Raja and Anil and Amit and Mr. Gopinath. But thank you. This is spectacular. And this is going to be one of those treasured talks which are going to sit in our YouTube archives. For those of you who are looking forward to resuming face-to-face learning, AO North America Hand has wonderful courses coming up. As you can see here, you can always visit our website. And in terms of webinars coming up, Anil, next slide. So we have, following the conclusion of this series, we have the last series in my tenure as chairman of AO North America Hand Education. It's on complications in upper limb surgery starting May 5th for 6 weeks. But before we go there, we have a spectacular session lined up in 3 weeks, not 2 weeks, but in 3 weeks on April 7th. And we've called that the International Roundtable, where we'll have 13 surgeons from 13 countries presenting one surgical trick within 5 minutes or 5 slides, whichever comes first. And that should be spectacular. And then, as you can see from the slides, we have some other webinars coming up as well. So once again, thank you, Raja, Anil, Amit, and Mr. Gopinath. It was wonderful. AO team, as usual, you've done a spectacular job. Max, Abigail, and Jennifer, AO North America Hand Education Committee. Good night, guys.
Good night.
Thank you.